All right, so we have discussed the limb leads and the augmented vector leads. So that was the 3 limb leads, 3 augmented leads. So 3 plus 3 is 6. And now we have 6 more leads to go. The 6 precordial leads. So 6 plus 6 is our 12 lead EKG. The pericordial leads that chase across our chest are literally to be placed in very specific areas. V1 is to be placed at the 4th intercostal space, right sternal border. So how do you find that? Well, put your finger on your clavicular notch here and palpate down a couple of centimeters, and you'll feel this. You'll kind of feel a bony ridge, which is the connection, the bony connection between your manubrium to the body of your sternum. And right off of that, that's your 2nd rib. So move down a little bit and sit in a kind of softer space. That's your 2nd intercostal space. Move down 3rd rib, soft again, 3rd intercostal space, 4th rib, 4th intercostal space. So you really need to do that and practice on your family members and patients and really do it to get it in the right spot, because deviation in the wrong spot can really cause a misreading of a 12-lead EKG. It can make a vast difference in the interpretation. On a historical note, I actually worked at Stanford University Medical Center when Dr. Norman Shumway did the first heart transplant. And one of the early ways of determining rejection was a change in amplitude. But if the technician or the nurse was off in any way in the placement of these precordial leads, you couldn't compare one EKG one day to an EKG the next day, because they were not comparable. They weren't done exactly the same. So he actually began to tattoo a little dot in the OR for the precordial leads, so that everybody would put them in the same spot. So V1 is 4th intercostal right sternal border. Move right across 4th intercostal left sternal border, and that's where you place V2. You hang off on V3 for a minute. Go down to 5th intercostal space now, left mid-clavicular line. We know this well as the apex. We know this as the mitral area. We know this as the point of maximal impulse when palpating the heartbeat. So that's where you put 4. So then you put V3 in between 2 and 4. Move out to the 5th intercostal space, left anterior axillary line, and that's V5. 5th intercostal space, left mid-axillary line, and that is V6. So you really should, if you're going to be working in cardiology, you're going to be working in intensive care, you really should memorize things. It's not all that hard. All you're talking about is the 4th intercostal and the 5th intercostal space, and moving from right sternal border, apex, anterior axillary, mid-axillary line. And if you were to look at the way the flow of electricity is going through the heart and the EKG patterns that you would see from this, remember that picture of the flow of electricity, and you can see this little line. The flow of electricity through the heart, the main vector is beginning from the right atrium towards the apex of the heart. So if you had your electrode here in the V1 position, what you see is the flow of electricity coming towards it a little bit. I get a little positive deflection. But once it has passed this electrode, the flow of electricity is now going away from my electrode. This would be analogous, really, as to sitting on my right shoulder and my right arm, and think of it in that way. And so in a V1, the actual deflection of the QRS is negative. And this is confusing and worrisome to novices when they're looking at EKGs, because you're used to seeing something upright, like a lead 2. But this is the normal picture of a V1. It is predominantly negative. In a V2, you'll see that the flow of electricity comes towards that electrode longer than it did in the B1, so I get a slightly more positive before it passes that electrode and now becomes negative. In B3, I'm kind of like here, I'm like halfway, half and half. So I get even more positive and then negative, and I literally get a biphasic waveform. B4, which is my apex, 5 and 6, are all very positive, so 4, 5, and 6. So we start with negative, negative, biphasic, positive. And you'll see that the R wave is just a little bit because it's coming at it for a short time before it becomes negative. Here it's a little taller. Here it's even taller, and then taller and taller and taller. We call this the R wave progression as you're chasing across the precordium from right to left. And if we see lack of R wave progression, if you were to look at your heart and say, what part of my heart am I looking at? Well, I'm really looking at the anterior and then outside lateral part of my heart. That's what angle of the heart I'm looking at, anterior lateral. So again, in looking at the pictures of the various leads, negative, negative, biphasic, positive, positive, positive on V1 through V6. So what do we want to look at? Why do we look at a 12-lead EKG? We want to look at specific changes in the EKG pattern that would let us know where we were at in an acute coronary syndrome by looking at the EKG. And we've seen this before. We've had this slide before in previous discussions. But if I'm having signs and symptoms of ischemia, I want to do my EKG, and I want to say, do I have ST segment elevation or not? If I have ST segment elevation, do I also have cardiac biomarkers that are positive? Do I have positive troponins, CKMBs? If so, ST elevation and positive biomarkers, I have an ST elevation myocardial infarction. I have a STEMI. Well, what if I don't have ST elevation and I don't have any positive biomarkers? Well, I'm just at unstable angina here. No ST segment, but I do have positive biomarkers. I do have positive troponins, CKMBs. This is now a no ST, no ST segment elevation MI, but it is a myocardial infarction. And due to some obstruction through coronary blood flow to some part of my myocardium. So what do I look at? And again, we have the area of necrosis, area of injury, and out here the area of ischemia. So the injury to the myocardium evolves, much as it evolves in a stroke, evolving the stroke in evolution. We have an MI in evolution. So we want to prevent the ischemic areas from becoming injured, and we want to prevent the injured areas from becoming necrotic. Once we're here, we can't do anything about it. It's dead. But what do we look for? The earliest sign that we're looking for, ischemia, is T-wave inversion. Remember, this is the isoelectric line. But look, the T-wave is inverted. As we get to the area of injury, now we get ST segment. It didn't come back to baseline. Now I've got ST segment elevation and an inverted T-wave. And here, with the zone of ischemia, I now have an abnormal deep wide Q along with my ST segment elevation and my inverted T. So another way of looking at it is ischemia is an inverted or flattened T wave. Injury is ST segment elevation. And remember, this is kind of analogous to a tombstone, not a good sign. And then necrosis is a wider and deeper than normal Q wave. So we also can define and look at leads that are looking at a part of the heart. And if we were to look at the lateral wall of the heart, what leads would look at the lateral wall of the heart? Well, anything on the left arm, which would be lead 1 and AVL, and anything on the lateral aspect of your chest, of your thorax, which is here V5 and 6 at the anterior and mid-axillary lines. They're all looking at the lateral wall. Well, if you had changes in these leads and you decided that you had a lateral wall infarct, it is literally the circumflex branch of the left coronary artery that is involved. What if I saw EKG changes in leads 2, 3, and AVF? In those 3 particular leads, the positive electrode is on the left leg. Well, if the left leg, if you're a camera down there on the left leg and you're looking at the heart, you're looking at the underbelly of the heart, or the inferior wall of the heart. And that is supplied by the posterior descending branch of the right coronary artery. Right here, V1 and 2 is the septal, ventricular septum, and that is the septal branch of the left anterior descending. A bit more lateral, leads 3 and 4, or V3 and 4, pardon me, left anterior descending. And if I had a posterior wall from my left circumflex going around in my left atrioventricular groove and down posteriorly behind the left ventricle, that would be a posterior wall infarct, and I would see reciprocal changes in V1 through 4. So it's hard because this doesn't show it that dramatically in color, but here's our right coronary artery, and it descends and it goes around and behind the heart. So if I had an infarct or something involving my right coronary artery, that is the right coronary artery supplies, for most of us, the inferior, or the posterior, pardon me, area of my heart. It's a little darker here. That's being supplied by my right coronary artery. If I were to look at my left anterior descending, that's the anterior, the septal and anterior part of my heart. And then if I were to look at my left circumflex, which lives between my left ventricle and my left atrium and going around and behind the heart, it's supplying the lateral side here and posterior. So try to look at the heart as a hologram, and it'll help you to try to realize where things are. So again, localizing, another way to look at it is V1 and 2. I'm literally, this is my septal wall between there. So changes in leads V1 and V2, I'm looking at septum. V3 and 4, I'm looking at the anterior wall of my heart. And out here in my axillary area, I'm looking at the lateral wall of my heart. So this is just yet another slide that shows lateral views. It would be leads 1, AVL, V5 and 6. Anterior views would be the precordial leads V3 and 4. Septal would be V1 and 2. And the underbelly, or the inferior wall of the heart, would be the ones on the leg, 2, 3, and AVF. So we're going to look at this slide, and I'm going to have my colleague, Jelena, who's the Gurnix online guru and has been helping me do these webinars. She's going to assist me, and so we're going to adjust the lights a little bit, and I'm going to try to demonstrate what we mean by this. If you could think of the heart, and looking at the heart, she's demonstrating you can see the flow of electricity starts off in the SA node and traverses down towards the apex of the heart in this direction. That's the main flow of electrical pathway. So as you can see, in an AVR, for example, where the positive electrode is on my right arm, the flow of electricity is not going up towards my right arm at all. It's totally going away, which is why in an AVR, everything I see is a negative deflection. And then I'm going to have you, if you would please hold the heart up, and I'm going to try to demonstrate something here with a flashlight. Okay, and I'm going to aim this flashlight. Here's her heart. If I were an electrode on her left leg, and my positive electrode would be in lead 2, 3, and AVF, it would all be on my left leg, and I'm the eye, I'm looking at the heart. What part of the heart am I looking at? I'm looking at the underbelly of the heart. I'm hoping you can see that. And that would be analogous on this particular slide here. Leads 2, 3, and AVF are all looking at the underbelly of the heart. And that would, nothing on the precordium, no lead up here, none of the V leads are looking at the underbelly of the heart. And so, so thank you very much, Jelena. So this is, you can think of using that kind of method or idea or approach to your analysis of the EKGs. So what we had just described was a flashlight or a camera or an eyeball on the left leg, the positive electrode in leads 2, 3, and AV foot are all on the left leg. They're all looking at the underbelly of the heart. So that when I would look at my 12-lead EKG and I saw changes, here in 2, 3, and AVF, I've got a pathologic Q, ST elevation, and T wave inversion in leads 2, 3, and AVF. So let's look at it. Leads 2, I've got ST segment elevation. Leads 3, certainly look at that tombstone. And AVF, again, tombstone and inverted T's. But all my other leads did not show changes. So I'm seeing a pattern of EKG changes that are consistent with these particular leads. And I know that in these particular leads, I'm looking at the inferior wall of my heart. Let's look at a lateral. Shine a light here. This would be analogous to standing on the patient's left side or and shining a light at them. Well, what's on the left side? Lead 1, your left arm. AVL, left arm. On the precordial leads, E5 and 6 in your axillary area. These are leads that are all looking at the lateral wall of your heart. So again, looking at changes in lead 1, AVL, V5 and 6, and everything else being normal, I would identify lateral wall damage. So you can study these slides and try to keep in mind the impact. This is not hard to do. Just try to envision your heart as a holistic view, as a hologram, and think of what side of the heart you're looking at in relation to where that positive electrode is. Jelena, would you just hand me that heart for a moment? Thank you. So again, if you were looking at electrodes on the foot down here, you're looking at the underbelly of the heart. If you're out here on the, I get dyslexic when I'm trying to see myself. This is left side, thank you. If I was looking at the left side of my heart, it would be because something out here. Left arm, side of my thorax was looking at that part of the heart. So you can really get a 360-degree kind of view, thank you, of what's going on in the heart. So again, looking at an inferior wall, we would see changes in leads 2, 3, and AVF, all of which have the positive electrode on the foot. And the foot is looking up at the underbelly of the heart. So for EKG tips, look for EKG changes in groups of leads, and then visualize in yourself, in your mind, what part of the heart do these groups of leads look at. Look at your T waves. They're normally positive in all of everything except AVR, where everything's negative, and in a V1, they can also be negative. And they may initially increase in amplitude followed by inversion in an acute event. ST segment changes. Remember, we're talking about ST segment elevation or non-ST segment elevation, MI. So normally the ST segment is within 1 millimeter of the isoelectric line. That's one little box. So ST depression would be greater than 1 millimeter. That would be ischemia, okay, the earliest part of injury. With ST elevation, now I've either gone to injury or I've actually got an infarct. And if I see a new left bundle branch block, this may be indicative of an infarction as well. Other tips, that positive Q wave. A Q wave is part of a normal QRS, but it is significant and abnormal if it's at least 1/3 the size of the R wave. So it's deeper and it's wider than a normal Q wave would be. And as I had said, R wave progression, loss of R wave progression across the precordium in your V leads is indicative of an anteroseptal infarct. So a non-STEMI, a non-ST segment elevation, as we previously discussed, usually results from a partial occluding thrombus and is characterized by ST depression, T wave inversion, or nonspecific elevations. But a STEMI is usually resulting from total occlusion by a thrombus, and with your positive biomarkers is an ST segment elevation MI. And in looking at this, if you look at, here's a subendocardial injury and ST segment depression. You can see how here's where your isoelectric line is. Your ST segment is way below. It's depressed below your isoelectric line. And a subendocardial MI, you can infarct, remember, the innermost aspect of your heart and not the full wall, as you see here in a transmural, because recall that the coronary arteries enter from the outside and move in. So the endocardial surface is the most vulnerable to any decrease in blood flow. Here in a transmural injury, the full wall thickness, now you see that tombstone. That's not a good sign. So compensatory mechanisms to maintain cardiac output after MMI. We've gone through this slide in previous lectures, so let's just have you recall it, that with impaired with infarction, we have decreased stroke volume. There are baroreceptors, sympathetic activity to all maintain cardiac output. There's the whole renin-angiotensin-aldosterone activation to try to maintain blood flow to the kidney, but it acts to congest the cardiovascular system even more. But all of these together increase in ventricular wall tension, hypertrophy of the heart to do more work, all in a long-term attempt to maintain stroke volume and cardiac output. So cardiac dysrhythmias themselves, now we've talked about the 12-lead EKG and how we can look at a myocardial infarction or damage to the heart. But that's a 12-lead EKG, and we certainly don't have our patients connected to a 12-lead EKG machine all the time in the hospital setting. When we have them in the units and the telemetry or the ICU unit, we have them connected to an abbreviated system. Normally, most often, a 5-lead. Instead of having 10 electrodes on the patient, we have 5 electrodes, one in each subclavicular space, one in the inferior cluster margin border, and this mimics the 2 arms, the 2 legs, and then we have a 5th lead, which would be the precordial lead, which we can place anywhere we want, V1 through V5, so that in that we can in that particular system, with only 5 electrodes on the patient, we can look for rhythms. It's not a diagnostic. It's not a 12-lead to diagnose. It's just looking at rhythms. So the rhythms that we're going to be looking at are classified by their severity. Are they lethal? Are they Mickey Mouse? Who cares? Where did they originate? In the atria, in the ventricles, for example. And the goals of collaborative management is we want to rapidly recognize so that we can treat, we want to restore cardiac rhythm, and we want to prevent sudden death. So in a dysrhythmia analysis, we want to look at rhythm. So that's, are the P's to P's, the R to R's, and the T to T's? Is everything totally regular and like a metronome? We want to calculate the rate, which is taking the number of small boxes and dividing that into, not divided by 50, divided it into 1,500. We want to look at P waves. Do we have one P wave for every QRS? We want to look at our PR interval. Is it normal, 0.12 to 0.20, or 3 to 5 little boxes? We want to look at our QRS. Is it rapid and brisk, demonstrating adequate contractility, 0.06 to 0.11 seconds? And the cardiac dysrhythmias that we're going to look at in order of severity. Pre-lethal is this laundry list: premature atrial contractions, atrial fib, atrial flutter, sinus tach, etc. And these are all in the atria. PACs, atrial flutter, AFib, sinus tach, sinus arrhythmias, etc. Or is it potentially lethal? And now we're talking about our heart blocks, our ventricular rhythms such as VTach, VFib, no rhythm at all, asystole. The origin of the dysrhythmia, was it premature ventricular contraction? What is a block out of the AV node? Was it VTach? Was it VFib? And so now, before we get into dysrhythmia analysis, we're going to take a short break.